We all hope for the best when we interact with healthcare, right? We trust the system. But have you ever really stopped to think about what goes into keeping us safe during that care?
It's a huge background operation, really, and incredibly important.
Absolutely. So today we're going to dive deep into that very topic, patient safety.
And it's probably more critical than many people realize. The numbers around medical errors, well, they're quite startling.
Startling is one word for it. There's this estimate that most of us, actually, will probably experience at least one diagnostic error sometime in our lives.
Yeah, and unfortunately, those errors aren't always small things. They can have serious consequences.
Exactly. We were looking at this toolkit from the American Society for Clinical Laboratory Science, ASCLS, about using quality indicators. They point out some, frankly, alarming figures, like around 12 million Americans affected annually by diagnostic errors just in outpatient settings. And maybe half of them suffer some kind of harm because of it.
And that's just outpatient. In hospitals, the conservative estimates are, 40,000 to 80,000 deaths a year just from diagnosis failures?
Right. And then there was that Johns Hopkins study suggesting overall medical errors could be linked to over 250,000 deaths a year in the U.S. That's sobering.
It really is. And what's crucial to understand, something that came out of that landmark to err as human report, is that these often aren't just isolated mistakes by one person.
Right. It's usually about the system.
Exactly. Flaws in the processes, the conditions, the way care is actually set up and delivered, that's often where the problems lie.
Okay, so our goal today isn't just to dwell on those, scary numbers. We want to explore what the healthcare system is actually doing about it. How are they working to make things safer for all of us?
And we'll be looking closely at the role of medical labs, using that ASCLS toolkit you mentioned, and specifically these things called quality indicators.
We also want to get a wider view, so we'll bring in an article from PSNet, the Patient Safety Network, called Measuring Patient Safety. That gives a good sense of how safety measurement has evolved.
And how it's still changing.
And we'll touch on the national patient safety goals, also from PSNet, which are kind of like a framework for proactive safety steps.
Plus, we can't forget the nurses. We've got an AHRQ PSNet primer on nursing and patient safety that really highlights their critical role, AHRQ being the Agency for Healthcare Research and Quality.
Right. So pulling all this together, the mission here is really to understand how these quality indicators, these goals, all these initiatives are aiming to cut down on harm and, improve our outcomes when we need care.
Making things safer, basically.
Okay, so let's start digging into that ASCLS toolkit. Quality indicators in the medical lab. It sounds technical maybe, but what are they really in simple terms?
Yeah, you can think of them as sort of vital signs for healthcare processes. The toolkit defines them as specific measurements that help screen for potential problems, adverse events that a patient might run into because of the care they receive.
Okay, so like little flags.
Yeah.
Measuring specific things that might signal a weak spot.
Precisely. And the key idea, as the toolkit points out, is you can't really improve something if you don't measure it first.
Makes sense.
So in the lab world, this means looking at every stage of what's called the total testing process. They even have a diagram showing it. It covers everything from the moment a doctor orders a test to how the sample, maybe blood, is collected, then how it's analyzed in the lab, how the results are reported, and even how the clinician interprets those results and tells the patient.
Right. So it's way broader than just was the lab test itself accurate. It's the whole journey of that test.
Exactly. All the steps before and after the actual analysis. And these quality indicators can be applied to any part of that journey.
Like the pre-analytical phase, before the testing.
Yep. That includes ordering, collecting the sample. Then there's the analytical phase, the testing itself, and the post-analytical reporting, interpretation. Appendix 1 in the toolkit actually lists a whole bunch of examples for each phase.
Okay. Give us a couple of concrete examples. What kind of things are they actually tracking?
Well, in that pre-analytical stage, maybe they track how often blood gets drawn from the wrong patient. Or samples get mislabeled. That's a big one.
Oh, wow.
Or even issues with the sample quality itself. Like if a blood sample gets damaged, hemolyzed during collection, making it potentially unreliable.
And during the testing, the analytical part.
There, they'd look for errors in the actual test results, obviously, or maybe failures in the lab's internal quality control checks.
Right.
Then post-analytical indicators might track, say, how quickly critical results get reported back to the doctor, or even serious errors like giving a patient the wrong type of blood in a transfusion.
Gosh, it feels like there are so many points where things could potentially go wrong.
There are, and that's why measurement is so important.
So is the main point of tracking these just finding where the mistakes are happening? Or is it more constructive?
Oh, definitely more forward-looking. Section 2 of the toolkit explains the goals are really about understanding how well processes are actually working, identifying the best places to focus improvement efforts based on evidence, and figuring out which changes will genuinely improve patient safety and outcomes.
So find the problems and figuring out how to fix them effectively.
Exactly. And then measuring again to see if the fix worked. It's also about standardizing how this data is reported so you can track trends over time, maybe compare performance.
So like if a lab notices more mislabeled samples, they could try a new labeling procedure, track that specific indicator, and see if the error rate goes down.
That's the idea. The toolkit mentions the PDSA cycle plan, Do, Study, Act. It's a classic quality improvement method.
Plan, do, study, act. Okay?
You plan a change, you implement it, you analyze the results, study, and then you decide your next step based on what you learned, act. Maybe refine it, maybe roll it out wider.
Is there an example in the toolkit?
Yeah, Appendix 2 has a case study about an emergency department trying to reduce delays because lab samples were getting rejected.
Yeah.
They tracked rejection rates and tried different strategies. There's even a graph showing how the rejection rate changed over months as they implemented things.
That makes it tangible.
Yeah.
And it's interesting they stress that indicators shouldn't just measure things fully inside the lab's control.
Absolutely. That's key. Things involving nurses collecting samples or doctors ordering tests. Patient safety is a team sport.
Requires a systems view, right?
Totally. The toolkit emphasizes looking at all the interconnected parts. They even suggest questions for choosing indicators, like, does it relate to the core aims of healthcare safety, effectiveness, patient-centeredness, timeliness, efficiency, equity?
Okay, so lab quality indicators are like an early warning system, monitoring the whole testing process. How does this connect to the broader picture, like that PSNet article on measuring patient safety?
Well, that PSN article really traces the evolution of patient safety measurement, especially since 2Air is human. Right.
Initially, a lot of it involved manually reviewing patient charts after the fact to find adverse events, which gives rich detail, but
slow and expensive.
Exactly. Very time-consuming, not real time. Then you had administrative data like billing codes. Cheaper, but often lacking clinical detail and, again, backward-looking.
So both had drawbacks for timely improvement.
Sure.
Yeah.
The article then talks about the big shift towards digital quality measures, DQMs. This has really been powered by electronic medical records, EMRs.
Ah, the digital revolution hitting healthcare safety.
Pretty much.
Okay.
CMS, the Centers for Medicare and Medicaid Services, is pushing this hard, including things called ECQMs, electronic clinical quality measures. These can often pull data straight from the EMR.
And the advantage of going digital is?
Well, much faster data collection, potentially richer clinical detail. And importantly, it helps shift the focus. Instead of just measuring if a process step was done like, was the checklist used? You can better measure the outcome, what actually happened to the patient.
Okay. Process versus outcome. That makes sense. Yeah, they give an example of a measure for severe low blood sugar hypoglycemia. Using lab data in the EMR, hospitals can track if patients on certain meds actually had a severe episode. That allows for quicker identification of potential issues.
You want to know if the steps taken actually prevented harm, not just if the steps were taken.
Precisely. And Michelle Schreiber, who's interviewed in that PSNet piece, talks about CMS's strategy and aiming for all quality measures to eventually be digital.
Wow, all digital.
She really stresses the need for timely, interoperable data, something the pandemic really highlighted.
Interoperable meaning systems can actually talk to each other and share data easily.
Yes, and that's huge for safety. Errors often happen when information gets lost between different doctors or hospitals or care settings. Better interoperability means better measurement and hopefully safer care.
Schreiber also mentioned bringing the patient's voice into this more, right? Getting their perspective on safety.
Absolutely. That's seen as a really vital next step. There's a National Steering Committee for Patient Safety pushing for measurement systems that cover the whole care journey and actively include feedback from patients and families. Things like patient-reported outcome measures specifically about safety.
So it's moving toward being more holistic, more proactive, using tech, and listening to patients. Now, where do the National Patient Safety Goals fit in this landscape?
The National Patient Safety Goals, which come from the Joint Commission, are basically a set of very specific, actionable safety standards.
For hospitals and other places.
Yeah, hospitals, clinics, nursing homes, labs, lots of settings. The PSNet primer explains they were a direct response to error is human. The idea is to build proactive system-wide processes to stop errors before they happen.
So less about blame after the fact, more about prevention up front.
Exactly. Getting away from just blaming individuals and focusing on improving the system.
And what kind of things do they cover?
A whole range. Things like making sure patients are identified correctly, right patient, right procedure. Medication safety is huge. Preventing infections picked up in healthcare settings. Preventing falls, bed sores.
The fundamentals of safe care.
Right. And a really important recent addition, as the primer notes, is emphasizing healthcare equity as a safety issue, pushing organizations to find and fix disparities in care between different patient groups.
That feels like a crucial evolution, recognizing safety isn't equal if care isn't equitable.
It really is. And there's accountability, too. The primer points out that meeting these national patient safety goals is actually required for accreditation by the Joint Commission.
So there are teeth to it.
Definitely. And organizations aren't left on their own. There are resources like the Safer Together, a national action plan, to help them implement the goals, find gaps, and track their progress.
What does that action plan focus on?
Key things like fostering a real culture of safety in the organization, getting patients and families more involved, making sure the healthcare workforce itself is safe and supported, and promoting continuous learning across the whole system.
Okay, it really feels like all these pieces connect the specific lab indicators, the broader digital measurement, these national goals setting the standard. Now let's talk about the nurses. That AHRQ primer paints them as absolutely vital.
Oh, absolutely. Nurses are truly on the front lines of patient safety. As the primer says, doctors make the big diagnostic and treatment calls, but nurses are often the ones providing that constant bedside care.
The eyes and ears, constantly monitoring.
Exactly. Monitoring for subtle changes, catching potential errors, communicating crucial information back to the whole team. Their vigilance is just essential.
And the primer really hammers home the link between nurse staffing levels and safety, doesn't it?
It does. Study after study shows a clear connection. When nurses have too many patients to care for simultaneously, well, safety can be compromised.
More errors happen.
Yeah.
Worse outcomes.
Yes, links to more patient safety events, more complications, even higher mortality rates. It's not just about raw numbers either. It's about patient acuity, how sick they are, the turnover of patients, the skill mix of the staff. All that factors into safe staffing.
And some states have actually mandated minimum ratios because of this.
That's right, recognizing how critical that link is.
The primer also mentions things beyond just staffing numbers, like working conditions, interruptions, long shifts.
Yeah, that's important too. Nursing is demanding work, frequent interruptions, equipment issues, working really long shifts or overtime. These can all increase the risk of error, especially with things like giving medications. Fatigue is a real factor.
It degrades attention, judgment.
Understandably. And the primer introduces this idea of missed nursing care.
Missed care, what does that mean exactly?
It means essential nursing tasks get delayed or only partly done or sometimes skipped altogether, usually due to time pressure or resource constraints.
And that has consequences.
Definitely. Missed care is linked to negative outcomes like medication errors, infections, patient falls, even higher chances of being readmitted to the hospital.
So what contributes to that missed care?
The primer highlights the most consistent factors are things we've touched on. Not enough staff, a poor or unsupportive work environment, and weak teamwork.
So ensuring enough staff, creating a positive culture, good teamwork, those are key to reducing missed care and boosting safety.
That's the takeaway. Standardizing care processes helps too. It all ties together.
Wow. It's so clear that patient safety is this incredibly intricate challenge. It spans everything from tiny details in a lab test process all the way up to system-wide goals and the day-to-day, minute-to-minute work of nurses.
Absolutely. And those quality indicators we started with, they're the tools, the measurable signals that help identify risks and drive improvements all along that chain, from sample collection to how results are used. The ASCLS toolkit really lays out how to use them effectively in that continuous improvement cycle.
And it's not just about catching mistakes after they happen. Things like the National Patient Safety Goals show the push for being proactive, embedding safety into the system itself, and focusing on system fixes, not just blaming individuals.
Right. And it's exciting in a way to see how safety measurement itself is evolving. That move towards digital measures Michelle Schreiber talked about, getting more timely, detailed insights, focusing more on outcomes that patients actually experience.
And that growing recognition of equity, too. making sure safety improvements reach everyone.
That's becoming central. And woven through it all is the absolutely indispensable role of nurses, their constant observation, their communication, and how much their staffing and work environment impact patient well-being.
It really underscores the complexity.
It does. So maybe the next time you interact with the healthcare system, it's worth just taking a moment to think about all these layers, these multifaceted efforts going on behind the scenes, all aimed at keeping you safe.
Yeah, because while errors sadly can still happen, it's clear there's a huge ongoing commitment to understanding why they occur and building better systems to prevent them. It's a continuous journey.
Definitely gives you a different perspective on the care you receive, knowing the depth of effort involved in trying to get it right every time.